My name is John Kim. I am an interventional endoscopist and the chief of gastroenterology at Los Angeles General Medical Center, and here with Josh Martin, who is an internal medicine resident at Loma Linda University. On behalf of my co-authors, I would like to thank GIE for the opportunity to present our study, Frequency and Predictors of Delayed Clearance of Prophylactic Pancreatic Stents After ERCP. Pancreatitis is the most feared adverse event following ERCP, and placing prophylactic pancreatic stents reduce the risk of pancreatitis in high-risk individuals. Society guidelines recommend prompt removal of prophylactic pancreatic stents 2 to 4 weeks after ERCP to reduce the risk of pancreatic duct injury. We decided to undertake the study from the observation that clearance of prophylactic pancreatic stents after ERCP is not straightforward. As interventional endoscopists performing high volumes of ERCPs, it is easy to overlook a patient whom a prophylactic pancreatic stent was placed 1 to 2 weeks ago, even when meticulous follow-up was initially intended. This could be due to a number of reasons common to endoscopic practice, including difficulties arranging and following up abdominal x-rays for patients referred from outside centers, assumption that short stents will likely self-pass, or even skepticism about whether prolonged pancreatic stent can cause harm. At the same time, some variation in adherence among endoscopists are expected. Given that even removal of biliary stents within 3 months are occasionally delayed, we suspected that a portion of patients who receive a prophylactic pancreatic stent may not receive timely evaluation and removal within 4 weeks from ERCP. Josh, can you walk us through key results of our study?
Yes, I'd love to. So at our center, we examined patients who received a first-time prophylactic pancreatic stent over a 9-year period after excluding those who had pancreatic pathology. Our primary endpoint was to determine the proportion of patients who achieved timely clearance of the prophylactic stent, defined by confirming passage or direct endoscopic removal within 4 weeks of that ERCP. During the study period, 4,724 patients received ERCPs, and 262, or about 6%, received a prophylactic pancreatic stent. Prophylactic stents were replaced by 13 endoscopists of varying years of experience. 71% received a short 3-centimeter pigtail stent. After ERCP, 10% of those patients developed post-ERCP pancreatitis, including 2% who developed moderate or severe pancreatitis whose spontaneous migration of the pancreatic stent was documented at 2, 3, and 13 days respectively. In terms of our study endpoints, approximately 2/3 of the patients had radiologic or endoscopic evaluation of the pancreatic stent within 2 weeks, but only about half of the patients achieved timely clearance of this stent within 4 weeks of the ERCP. On multivariate analysis, endoscopist tendency for timely clearance was the strongest predictor of the timely clearance of that stent. There were 11, 5, and 4-fold differences in timely clearance of the pancreatic stent among endoscopists in the top 3 compared to the bottom quartile. Furthermore, concomitant placement of a biliary stent also reduced the odds of timely clearance of the pancreatic stent by half. Other factors, such as insurance status and the absence of an internal flange, demonstrated an increased trend toward timely clearance of the pancreatic stent, but did not reach statistical significance. Finally, during a mean follow-up of 20 months, 2% of the patients with documented delayed clearance or delayed evaluation of the pancreatic stent developed new clinical or radiologic evidence of chronic pancreatitis.
Thank you, Josh, for the excellent summary of the key findings. Our results demonstrating that clearance of prophylactic pancreatic stent within 4 weeks of ERCP in only half of the patient is lower than expected, and highlight the challenges endoscopists face in clinical practice. Although understudied, our experience of suboptimal adherence has been hinted in other studies where prophylactic pancreatic stents were not meticulously tracked. Our study demonstrated that adherence to timely clearance of prophylactic pancreatic stent was driven by endoscopists rather than patient or procedure-related factors. For example, there was an 11-fold difference in timely clearance of prophylactic pancreatic stent between top compared to bottom quartile endoscopists, indicating a large variation. In terms of procedure-related factors, placing a biliary stent reduced the likelihood of timely clearance of pancreatic stent, indicating a complex interplay between the endoscopic management of biliary stent and prophylactic pancreatic stent. Although there is clear benefit of placing prophylactic pancreatic stent for prevention of pancreatitis, there have been alarming recent US data demonstrating a precipitous drop in the utilization of prophylactic pancreatic stents. We wonder if the challenges anticipated by the endoscopist in managing pancreatic stent after ERCP may also influence the decision to place one. However, we anticipate a resurgence in the practice of prophylactic pancreatic stent, given the results of a recent landmark multi-center study demonstrating strong protective effects of preventing pancreatitis even after administration of rectal indomethacin in high-risk patients. Given that endoscopy was a primary factor driving delayed removal of prophylactic pancreatic stent, establishing timely clearance of prophylactic pancreatic stent as a quality indicator at the society level and concerted efforts to improve physician adherence are needed. We urge the viewers to examine their own institutional data on the rate of timely clearance of pancreatic stent. If the rate is suboptimal, we recommend designating this as a quality indicator and implementing targeted interventions to improve the adherence, such as setting up institutional pancreatic stent pathway or providing regular physician feedback. Fortunately, physician behavior is more modifiable than other factors, and targeted interventions to improve adherence may have the greatest impact. Finally, additional studies evaluating the negative consequences of prolonged retention of prophylactic pancreatic stent can further highlight the importance of this practice. We would like to thank the viewers again for the opportunity to discuss our paper.